I think that's fine. That's
all right. Let's go.
Good morning and welcome to the Quality Network for Older Adult Mental Health Services webinar. My name is Fatima and I'm the Deputy Programme Manager on the network, and behind the scenes we have Rob Lowe producing this session. So today we are absolutely delighted to have Dr. Vishelle Kamath with us. She is a consultant psychiatrist at St Andrews Healthcare, and she is also the chair of our QNOAMHS advisory group. So Vishelle's been developing a sort of guidance for St Andrews Services on infection control and how to manage the spread of COVID-19. And today she will be sharing with us her experience of this and the steps taken to reduce the impact of COVID-19 in order to keep patients as well as staff safe. But before I pass you on to Vishelle, here are a couple of housekeepings and just a bit of introduction to the network for anyone new. If I can click, oh, come on, click. There we go. Housekeeping. So this is a live event, as you will know, and you are all on mute, and unless you are a designated speaker, so there's no need to worry about interrupting us. The webinar will be recorded and uploaded to our Knowledge Hub, which is an online resource centre, currently only available to our QNOAMHS members. However, we will make sure that this gets published on the website. And when it does, I usually send a little tweet, and the CCQI tweet and nobody retweets me. But equally, we'll be sharing this out through our dot mailer and our general emails to anyone that's signed up, so you can share it with your colleagues. Please use the chat function to ask any questions. And if you find that difficult, you can email us your questions. We'll do our very best to pick them up. However, if we don't, we will get back in touch with you after the session with anything that we haven't picked up. So this is a free event accessible to everybody, and including non-members and the general public. For those of you who haven't worked with us before, we are a membership network. And I guess we work with older adult inpatient mental health services to improve the quality of older adult mental health services, and we do this by a process of peer review and self-review to support services to improve the quality of the service and for the purpose of accreditation using our set of quality standards. We would highly encourage all trusts as well as independent providers that are providing service to older adult mental health services to be part of our network. And our vision is to ensure that each and every older adult receiving care have access to the highest quality of care that is available to them, and for staff working on these wards to have access to the correct training and support that they need to deliver the service. So we have recently developed the 5th edition of our standards, and if you're thinking about joining a network, this is the best time to join us, as this set of standards really focus on, I guess, working, that co-production model of working with the patients, carers and staff involved in delivering care. We are also currently, I guess this is a difficult time for many of us, so we're currently thinking of new ways of developing our service. So we've been working hard to, I guess, thinking about other ways of disseminating learning, so through our webinars, and we're also planning our virtual review. So in the past, services had, I guess, were able to access face-to-face reviews, but in this current climate, which is not possible, so we are designing the virtual reviews, which no doubt will be a huge learning for the network and as well as for our members. So apart from accreditation and I guess quality improvement, we also offer opportunities for services to engage with each other in the process of, I guess, sharing learning through our special interest days and our our annual forums. So if you are interested in becoming a member and want to learn more about the benefits of membership, please do email us and we can support you and to decide which type of membership suits you best. So without further ado, please let me pass you on to Vishelle.
Thank you, Fatima. Sorry, just want to make sure that you can see my Are you all able to see the presentation?
Yes, we can see you.
Can you see the presentation? I just want to make sure.
Presentation as well.
Thank you very much. So thank you, Fatima, for your introduction. So my name is Vishelle Kamath, and I'm an old age psychiatrist, but have been clinical director for the older people services. And one of the areas that when we came together as an advisory group earlier this year, so during the just past the onset of the pandemic, we understood that from each other that we'd all gone about doing different pieces of work around how we support our patients during this pandemic, and we thought about some of the things we had done in our own organizations, and we thought it would be useful to reflect upon those and share some of those experiences. So the purpose of today is to think about what our approach has been, and then to share some of your own experiences, and then have the opportunity to ask questions and think about how each of us has responded to the pandemic and learned from it. So in our organisation, so St Andrews, like all other health and social care providers in the UK, attempted to respond to the COVID-19 threat. And within the older adult services, I think we did that some weeks before the full impact of the pandemic took hold within the country. And that was because we had some understanding of the potential impact and the risks within the older adult services. We wanted to respond as proactively as possible. So at that time, so despite having extensive or existing pandemic plans and major incident protocols in place, it's fair to say that there were components of the coronavirus that were clearly unknown. And with advice and guidance unfolding day by day, we needed to figure out how we were going to manage that. So our position at St Andrews in responding to the threat and the considerable impact we knew it could have on our patients and staff led us to seek mirror guidance available nationally, either from the government or Public Health England, and where ambiguity existed, to seek to implement the guidance in ways that reflected the rules and restrictions and what was definitely necessary for our own older adult population. So what I'm going to go through today is having a look at the timeline. So when did Public Health England and when did the government publish guidelines around how we manage this pandemic? Then a little bit more about our own clinical approach. So what did we do in response to that? The clinical safety needed to happen with very close interface with how we kept the organisation operationally safe. And one of the key elements was how we managed anxiety, anxiety of patients, staff, families, our own anxiety with the emerging information and pattern on a day-to-day basis. And then some of the key lessons we've learned, which are ongoing. So we need to think about how we're going to continue to learn and manage. And part of the purpose of the event is to see whether this is helpful to others, and then to think about approaches that have been helpful in other organizations. Okay, so when we come to the timeline, so following the Her Majesty's government placing the country in lockdown on the 23rd of March, there were obviously events that took place prior to that, some of which happened in January and things like that, but it seemed quite distant from us. So, things were happening in China, but perhaps the impact of it, we weren't as aware of what that would be to ourselves at that stage. But post the government placing the country in lockdown, as an organisation, we went into an incident command structure, meeting 3 times a day. We also understood that just prior to that, we would need to think about having a group that offered expert, clinical, ethical, professional advice. So within the organization, we set up what we called a clinical professional advisory group, so that we could address some of the anticipated difficulties or some of the anticipated challenges and think holistically about how we supported our patients, our staff and families and carers with what the anticipated restrictions could be. So what I'm going to do is we'll talk about each one of those in some detail. So in relation to our clinical approach, so the ethical considerations we needed to think about. What we took very seriously was we needed to consider the compliance with the Mental Health Act and Code of Practice, so that it was used in its best endeavours to avoid blanket restrictions and overly restrictive practice. So with emerging guidance about keeping patients in isolation, restricting visits, we wanted to make sure that we had some sort of process for reviewing that guidance, so we didn't resort to what was overly restrictive. The CPAC met daily, so it was chaired and it continues to be. So it acts as a ethics committee and helped to ensure that there'd been a process of decision making and review to ensure that any decision complied with the relevant guidance, which often was changing really rapidly. The CPAC also had the role of considering exceptional requests to vary the application of the decision, so for individual patients and individual patient needs. And it does appear that the process has worked smoothly. It is chaired by the Executive Medical Director. CPAC has representation from all for senior clinicians across the organisation by the patient and carer representation, as well as the patient and carer group and lead. So there was clearly evidence of a patient voice, which is really, really important. So the other areas that we took into consideration when we looked at our clinical approach was about how we were going to continue to provide patient-centered care. So we thought about how we would try and support our clinicians to ensure that the focus on delivering high quality patient-centered care continued. So I'm going to talk a little bit more about that in a bit. Some of the areas in older adult services was around supporting nutritional and hydration needs. So I'm going to talk about that in a bit as well. Particularly in the older adult services about enforcing or enabling better advanced care planning and making specific plans about escalation of care. So thinking about the individual as a whole, whatever their mental health challenges were, the implications and interface with their physical health problems, and thinking about how we address those. The other issues that we needed to think about in our clinical approach was about leave, so people who visit, and we know particularly in the older adult services how important enabling people to have that contact with their families is. So all of that was part of our sort of clinical approach. One of the key aims was to have co-produced guidelines so that patients and carers had a voice, so that we could see things from their perspective. So we didn't want mandated, enforced guidelines. How we went about making sure that carers and families were informed in a timely manner, and they were offered the support, because not only had the way we needed to look after our patients changed as a result of the guidelines that emerged, but making sure that they had the support that they needed as a result of the imposed restrictions was really, really important. And the other area we had to think about was that should we have a death within our older adult services, we needed to consider things like duty of candor. So we wanted to make sure that we were open and transparent, and that there was some process of reviewing care, irrespective of the etiology, if somebody contracted COVID or if they died from it. So in terms of the person-centered approach, so once national guidance was available as to particular people who were especially vulnerable to COVID-19, we devised a risk assessment tool that helped our clinicians risk assess for these particular individuals, and then the tool also helped us to then think about, or help the support clinicians to think about, things like end-of-life care plans, escalation of care procedures, making sure that they'd had advanced care plan decisions with the individual, with their families, and if either of those were not possible, to make sure those individuals were independently advocated for. What I'm going to do very quickly is I'm going to try and show you the care plan, because it was quite, so we had a look to see if there was guidance from Public Health England and from the Department of Health in terms of an appropriate care plan or something that we could use to ensure our patients were risk assessed. Having not been able to find one, we went about thinking about how we devised this ourselves. So the care plan looked at the risk criteria that place somebody in a high risk group. So it would allow clinicians, both psychiatrists, nurses, so qualified nurses, and physical healthcare teams, to be able to monitor, so they understood and were able to identify their patients that were most at risk. So we used the public health guidance accordingly. We know that Public Health England then added other criteria in terms of thinking about people who needed to be shielded. So we then went about adapting the care plan and modifying it so that it included this additional guidance. And then we thought we used the tool to help clinicians think about whether these restrictions for every single patient within the service, whether they would have any impact on their leave, whether it would have any impact on their visitors, so on the ability for their loved ones to visit, or things like home leave and community leave. So at the outset, we would be able to have those discussions with families and things like that. A lot of people within the older adult services have spouses or partners that had physical health risks themselves that put them into a high risk or shielding group. So this allowed those prompts for the clinical teams to then begin to have those discussions. It also looked at things like end-of-life care, whether that was appropriate or whether they had end-of-life care plans in place. It prompted people to think about things like resuscitation status if it was not done already, and then specific treatment escalation plans, which could be documented within appropriate sections in the patient record that we currently have. So moving on from the care plan, we then, so post devising the care plan. So I'm just going to ask very quickly, because I've switched the slides. I'm just going to check with Fatima and Rob. Can you see that?
Yep, we can see.
That's fine. Sorry, I'm just making sure that the Teams is working as it's supposed to. So in addition to the care plans, the guidance from Public Health England, as per the timeline, came out about placing patients that had been tested positive in isolation. So we had to think about ways in which we could do this across our inpatient services without being overly restrictive, thinking about how we would support patients, particularly on our dementia wards who were wandering and things like that, about how they could be supported differently, but maintaining the safety for other individuals on that particular ward and for staff as well. And, you know, we each day decisions around using alternative spaces to allow people to wander based on their specific needs were reviewed within the CPAC. So constantly thinking about how we weren't being too restrictive and not putting in place interventions that would impact negatively on the individual's mental health, as well as cause any difficulties in terms of the ward teams having to apply restriction to maintain them. So the risk assessment tool, so we used the risk assessment and what we called a COVID-19 care plan, which helped us to identify those that were vulnerable and then think about what would happen if what the process for testing and when somebody was tested positive, how they would be managed on the ward. And we did this very much in anticipation of what was going to happen. So hopefully we're able to support our staff. So what we tried to do was not to be reactive to somebody becoming positive and then trying to think about how we were going to support them. So a lot of that thinking had to predate some of the guidance that came out from Public Health England. Like I said earlier, what we didn't have was the luxury of a bit of time to reflect and think and share good practice across organisations, which I'm hoping we can start doing better now. So in terms of thinking about co-production, so we worked really hard and will continue to do so. So in order to ensure that patients' voices were heard during the decision-making process, the head of patient engagement was included in the CPAC to ensure that all policies are looked at from a patient's perspective and that they were tested and discussed with patients and families themselves. And then we also wanted to make sure that we reviewed any complaints in the same way, so applied the same sort of rigor to see if there were any trends that had emerged because of the changes and restrictions that came about. So CPAC also did a sort of check and balance for difficult ethical decisions around other issues around patient care and restrictive practices, which we would test out through the patient engagement team with individuals themselves and their families. In addition to that, we tried to make sure that support was given to the advocacy services because to ensure that they use technology to meet with patients as regularly as possible. We wanted to make sure they had access and that the ward teams would facilitate remote contact between patients and their families, and that advocacy would support that as well. Because we wanted, it is a vulnerable population, and making sure that the care was provided, was continued to be provided at the level that we aspired to during this period was really important. So we do have patients that are detained under the Mental Health Act, and we were an early adopter of the sort of video conferencing technology to facilitate hospital managers and tribunal hearings, as well as making sure that patients and families could have contact with solicitors and things like that for these hearings. And this was required as a sort of high proportion of the hospital managers are considered to be, some of our hospital managers fell into a vulnerable group as well, so we needed to think about how we supported them as well, so not just the patients in isolation. So another clinical area that we really needed to think about was nutritional and hydration needs. And within an older adult population, we work really hard to think about how we support people positively to maintain their nutrition and hydration, which can be the protagonist for other infections like urinary tract infections. We know that that helps in maintaining their overall physical health status, and with isolation guidelines in place with people needing to remain in their rooms, we needed to, and having less contact with their families who are usually very instrumental in help supporting that need. We really needed to think about, having flexible meal times, about supporting somebody, having a remote session with the family member if that helped their eating, looking at different places on the wards and things like that that would support their eating. We're in the process, so we started the process of having a discussion with, I don't know if anybody knows, there's a thing called jelly drops, which are little sweets that were devised by somebody who had a gentleman who had a relative with dementia and was not drinking as well. So we looked at different ways to support hydration. So we'd already been in discussion with the developer of jelly drops, but what we did is we tried to expedite using those sorts of interventions on our old adults wards, which we are evaluating as well to see whether the patient response to them has been good. So another part of that clinical approach was thinking about how we kept carers informed about whether there was any pattern of emerging complaints around the care that we were delivering within the changed constraints, and then also think about where there was good practice, compliments, and how we took those compliments on board and shared the areas of good practice across all of the wards as quickly as possible. So we do that at other times, but we wanted to see how we could expedite that. We also looked at how we could identified, validated, and recognized staff during this period that had gone beyond the call of duty. So we had processes to do that before, but we wanted to see how we could amplify those processes given the increasing demand on them, and also as a means of communicating the good practice across the organisation. So in terms of keeping carers informed, so we sought to keep patients and carers informed at every opportunity possible. A letter was sent from the executive medical director to every patient's family, setting out what we were going to do as an organisation to keep their relatives safe, and also explaining the rationale why certain decisions had been made. The carers engagement team regularly kept in touch with patients and carers, and endeavoured to answer their queries and concerns in an expedited, timely manner. So we didn't adhere to the regular periods of times in which those concerns and complaints or any issues they had. We tried to see how we could be much more responsive during this period. And what was very clear is that we knew that particularly in our old adult services, that most of the patients fell in a high risk group. We knew that many of them had other physical health comorbidities, and some of them had already had end-of-life care plans in place with decisions around resuscitation and those sorts of things. So we wanted to be sure that we knew that there may be individuals that, despite the amount of care they received and that they were likely to be at high risk of dying as a result of infection with the virus. And we wanted to make sure we communicated openly and transparently with families and carers. And and we have had some deaths in the organisation, and they have been in the older adult services. So doing that and making sure that throughout the period of ill health or decline in health, that communication with those communication channels were as open as possible, and that we recognized that it was incredibly difficult for families at a time when there were already nationally imposed restrictions on travel and those sorts of things. So keeping all of those things in mind, we thought we went through the process of thinking about how we support them at this extremely difficult time. We also had to be very conscious of how we supported our staff. And I'll talk about how we manage some of those anxieties amongst our staff. But in order to allow them to care for individuals in the way that we desired, we had to make sure that their anxieties were managed as well as possible. And so I'll talk a little bit about how we went through that process and what is being done on an ongoing basis. So in terms of thinking about how we remained operationally safe, I said to you that the organisation had an incident command structure in place, but the things that have, discussed within that have a direct impact on remaining clinically safe was around staffing, having sufficient numbers of the right staff in the right place, making sure things like PPE were addressed because staff anxiety would increase significantly. So I'll talk about each of these individually, looking at our infection prevention and control guidance and whether that needed to be supplemented, looking at things around how we manage sickness and how we supported people to work remotely, but still within the care environment itself, have sufficient individuals to be able to deliver that care at a quality that we would want for ourselves and we'd want for our own families. And that is why maintaining operational safety was just as important. So in terms of PPE, so to date, we've not, as an organisation, had any shortages of PPE, but what was very clear was staff's anxiety about the use of PPE, the changing guidelines around what PPE was indicated and how we managed that, and that didn't come without any challenge. The difficulty, so some of you may work in NHS organisations, however, our organisation sat outside, so it is a charity, but so it wasn't regarded on the same footing as an NHS organisation, and it was so that there was some delay, but that didn't affect the way the actual amount of PPE that was available. We knew that given the lower priority, so we were regarded as lower priority as compared to our NHS counterparts, we knew that we would have to think about how we were much more creative in securing things like PPE supplies. So we used the support of the chairman and all sorts of things. So whatever means possible, we didn't leave. We made sure that there was a clear push to ensure that there was no difficulty with the supply chain, and providing that assurance to the staff was happening on a day-to-day basis. So I'll talk a little bit about some of the other support systems for our staff in managing their anxiety, which continued to date, and we're learning day by day how we can do that a little bit better, and using staff feedback to do that has been quite essential in that process. So the other area was around our infection prevention and control. And as an organisation, we've kept the IPC procedures under close review through the COVID pandemic, and we've had to review the infection prevention and control policy at a regular interval, and which is, up until as recently as the last few weeks, and that's likely to be an ongoing thing. So in terms of, I said to you, we had to react proactively, so we took decisions to limit the spread of infection across the charity, which included having to close the patient facilities, so things like swimming pools, gyms, the on-site, so the sit-in cafes. So we changed our isolation criteria. So previously, particularly on the old adult wards, we had isolation criteria that pertained to things like diarrhea and vomiting and those sorts of things, which required a certain number of patients to be infected or present with symptoms before they were placed in isolation. So those were changed because as soon as we had a single patient with symptoms, the ward was placed in isolation to try and limit the spread of the virus from the different inpatient environments. So reducing the volumes of non-clinical staff on site by adopting a sort of 50-50 working model. We went through the process of doing that, but it's making sure that we're still able to provide all of the support services that we needed. So we also went through the process of making sure that staff were provided with scrubs in areas that were in isolation. In our older adult wards, the staff across our dementia wards and things like that, staff already were wearing uniforms, but in some of our other mental health older adult wards, because we have a secure older adult ward and things like that, that was not the case. So the introduction of scrubs and things like that was different to how people had worked previously. We also made sure that all staff working clinical areas wore fluid repellent surgical masks, so not just when within 2 meters of a patient, which was what the PHC guidance stipulated at the time. We reviewed the frequency of mask changes for staff, and looked at how we'd increase those so that so that both the staff and patients remained safe. And as the pandemic developed, we kept infection and control procedures under review, and the threshold for thinking about making those changes and being proactive was decreased significantly. So in addition to that, we had discussions with external organizations to see whether our practices were being benchmarked against our infection prevention control practices, were in line with what they'd been considering through Medical Directors Forum, through the Public Health England discussions that were being held with the Director of Physical Health Care within the organisation. So in terms of having processes, these were evolving on a day-to-day basis. So making sure that we communicated to staff regularly, both on the ward, so across day and night, and making sure that that information got to everybody was really, really important, because we were fully aware that if we made changes and they weren't communicated and they hadn't been received in the way that they'd been intended, that we were likely to fall short of the intended purpose of changing that. So in terms of managing anxiety, As an organisation, and particularly in old adult services, where we knew that the likely impact was going to be greatest, we knew that we kept, we constantly focused on keeping the welfare of our staff at the forefront of our minds, and we also have a large proportion of colleagues from a BAME background, so making sure that we supported them in managing their own anxieties, and thinking about whether we needed to take steps in ensuring their safety. We took all of that into consideration. And so some of the more practical things was around, training, about people being able to maintain their training remotely. We put on additional training, so things like responding to a deteriorating patient, so making sure that people could access that information more readily and not wait for their planned training in a few months or whenever it had been planned before. We provided all medical staff with a specific training on the care plans, thinking about how they assess their patients in terms of being within a high-risk group or in a shielding group. So we didn't want to make assumptions that everybody would be able to do that without providing them with the intervention and the ability and tools to do so. So we have a research team as well, and the research team helped to think about, looked at the evidence, and would again to communicate it to staff as a whole about things like the increased risk of COVID-19 to colleagues from a BAME background, and what were the interventions, and how we would support them, looking at the current progress in terms of interventions available and emerging evidence in relation to why or what the etiology or protagonists for mortality in somebody who'd had COVID-19, and also about any emerging evidence around interventions to support somebody with an infection. So the executive team had endeavoured to be as open and approachable, and it included sort of weekly team video calls, both day and night shifts, and a daily briefing which outlined which patients, whether the number of patients and then the staff that were off, and any emerging changes that were happening and any challenges that they faced. So seeking everybody's input into thinking about resolving issues or the challenges, or finding solutions for them. So we do have an in-house occupation an occupational team and an occupational trauma psychologist who was supporting staff on individual wards and things like that as well. So that also helped. So we set up looking at a program to monitor staff's welfare, so to make sure that people had clear advice about maintaining their own health, maintaining their own well-being, because we know that our staff, like anybody else, will have anxieties about taking infections home to their own families and all those sorts of things. And all of that is ongoing. It is definitely work in progress. In terms of patient and carer engagement, so the patient liaison team have been actively supporting them, and wards and families, the ward teams have had regular contacts with families and thinking about how they support them with their own anxieties and maintain the communication and contact as best as we can, and with the recent changing guidelines about how we're able to do that better. So in terms of the lessons learned, I mean, that there's been a considerable amount of learning. I think in the early phase of the pandemic, We went about, it was very much sort of task focused, because we were very clear that we wanted to support particularly people that were in the more vulnerable groups, within our older adult services. So there was a lot of doing, but you know, as time has progressed, we've thought about how we reflect upon it, and what are the things we need to do, and how we need to improve so that we're continuously learning from it. I mean, we've been absolutely committed to learn from this tragic situation, and you know, we've attempted to take every possible step to keep our patients safe, to keep our staff safe, and offer the best care possible. So, like I said to you, we're going to think about. We've been having the opportunities to reflect with staff, which we have put in processes to do that. So for both for people that are working on site and those that are working remotely. We have had some deaths within our older adult services, and we've applied the I'm not sure if other people use it, but we use the mortality surveillance tool in terms of reviewing all deaths across the organisation. So even patients that had an end-of-life care plan in place, that were anticipated to die, who had not been for resuscitation and not for escalation of care. So we have applied the mortality review framework, and the reviews have been completed for every single patient that has passed away. So for some of the patients within our older adult service, so we have had a small number of patients that didn't have an end-of-life care plan in place. So we're rigorously looking at making sure that each of those are investigated under the NHS Serious Incident Framework. And what we've done is, as each review has come through, we're extracting the learning immediately to see whether there is something that we need to do in terms of improving practice. What we've done is we've also commissioned a sort of thematic review to look at our approach to the outbreak, and to then think about how we modify that approach as we go along, so that we're continuously learning from the incidents that have taken place. And we do that with colleagues that are external to the environment, external to the organisation as well. I mean, one of the areas that, and I will share that with you openly, so as we're reviewing some of those, so reviewing the incidents or patients that have had COVID positive, that have become COVID positive, and have either have recovered from the illness. So we're doing both. So where we've had deaths, applying that amount of rigor, but where we've not had deaths, also thinking about whether we've done things like advanced care planning, and those things as well as we should have. And there has been learning around the approach to a deteriorating patient, and we've looked at how we support staff in terms of learning from that, thinking about training, thinking about supplementing it with guidance and advice from our colleagues. So that is largely the approach that we've taken. The learning is ongoing, and I think that will be the case for a few months. The emerging pattern of the pandemic will be, I think we will need to see what happens in the days to come, with the lifting of restriction and things like that. We'll need to see what the infection rate is like and think about how we respond to that. So whether the existing plans we have in place, whether those need to be adapted at all. So that's what, so that brings my presentation bit to an end. What I would like is to see whether there are any questions and things like that, so that, and whether there are any experiences that people would like to share about their own, any areas of good practice or any learning that they've had to date that would help, that we can help each other with in terms of understanding how we support our patients and families and staff during this period.
Thank you, Vishelle. It seems like CMDs are having, a lot of load, reflecting and adapting in this difficult time. So let's do the questions. So we've got a fair few questions. I'm not sure if we'll have time to get through all of them, but we will share this with Vishelle, and then we can email you the response. So the first question is there national guidance on COVID-19 and Section 17 leave? I guess thinking about the possible second wave, the list restrictive environment balance with patient safety. So
as far as I know, and as far as from our organisational point of view, I don't think there's specific guidelines around Section 17 leave, which is part of the reason why in our organisation we set up the CPAC to think about how we could manage that in terms of, Section 17 leave in the community, in the grounds, to home, and we have largely done that on an individual patient basis, because everybody's need is different and the potential risks to either stopping or ongoing leave is very different. So it depends. So there is none that I'm aware of, which is why we make those decisions through our local. So it's not just done at so individual clinicians are not just responsible for it. So we can support the clinicians as well through through our sort of professional advisory committee.
Thank you. So the second question is, are you performing COVID tests for patients before admissions and at the time of discharge? And do you have isolation beds set aside?
So we do. So it depends where so when patients come in, as soon as they come in, we swab them for COVID, and we manage them in isolation until the swab is returned, and depending on the result of the swab. We've identified areas within the hospital, so particularly within our dementia services. It's really difficult to get patients to understand what isolation means. When somebody is able to do that, then they can be supported to remain in their own rooms and access certain areas that have been identified for them. But there are a lot of patients that it's really, really difficult. So we have had to identify areas that they could be managed to allow them to move more freely without having to apply any restrictions. So we do have some of those areas identified for that. We do swab our patients prior to discharge, because a lot of community, so if they're going to a care home, community placements are now asking that as a routine for them to be swabbed. And if they're going into their own home, then we're still doing that, because there are likely to be other vulnerable high-risk people within that environment as well.
I think this links into, I guess, testing. Are you performing antibodies test for patients?
So not at the moment. So not for staff and patients at the moment, but it's very much in the discussion in vogue at the moment. So we're trying to see how whether the antibodies test is going to. The difficulty is, I think the evidence is limited at the moment. So even if you do have antibodies, I don't think it's certain that you're protected from reinfection. So as our knowledge of the actual disease and virus improves, I think we'll have to see how that happens.
Okay. Okay, so Debbie would just like to know that if we could get a copy of the COVID-19 risk care template that you shared. If you're happy with that, Vishelle, we can circulate that.
Yeah, fine.
Yeah. So the final question we have. So high-risk shielding patients that were informal patients in informal patients. What was done to support shielding where any patient moved from informal status to detain, S2 then to S3 to ensure their well-being?
Sorry, Fatima, you're going to have to repeat that. That was
it's quite a mouthful. Let me just read that out to you again. So high-risk shielding patients, that started off with informal patients. What was done to support the shielding where any patients moved from maybe informal status to being detained?
So we didn't have any of our patients that applied to, but I think that it's each individual the circumstances, whether do they have the capacity to understand the restrictions placed upon them, weighing that, do they have the ability to be able to weigh up the risks in the balance, and then seeing whether the detention criteria is appropriate for them, because there's a lot of whether is it something that needs to be done under the Mental Capacity Act? Is it that it's that a deprivation of liberty safeguard applies? I think it's something that we've not had to do. We've not had to do for any of our patients, but I'm assuming that the same principles will apply.
Okay, so we've just got to have one more question, and I'm afraid that's it. But like I said, I'll share the questions with Vishelle, and we can get her response after. What are jelly drops?
So this is slightly. So I saw it. This sounds awful, but I saw it on Facebook. Somebody sent me a link. So you can Google them, and it's a very clever young gentleman whose grandmother had dementia and was not drinking, so they had a real problem with drinking. So it is to support their fluid intake, and it is water, but they're made like little sweets, so the person just pops them into their mouth if they don't have any dysphagia needs and things like that. So we were in the process of thinking about evaluation and how we use them, but given that we were acutely aware of the fact that people would that the impact of particularly not seeing their families, and some of the restrictions that came into play, that was likely to affect their eating and drinking. So we had to look at how we could use them faster than we had planned. So you can buy them off the internet. So you can buy them for yourself as well. They're available off the internet. So that's what jelly drops are.
Fantastic. Facebook supporting all the way. Brilliant. Well, that is our session. And thank you so much for Vishelle for giving us some of the time to host this webinar. Just before we finish, just note that we do have other resources available for members, as well as, I guess, those who are working with older adults. Let me just prop my slides back up, and then I can just give you, there we go. So we do have something called the QNOAMHS Shared Learning Forum, and this happens every 2 weeks. So the next one is next Thursday, 3 to 4 p.m, and it's just an opportunity for, I guess, members to come together and to share, like you said, the learning, but as well as to, I guess, to informally support one another in the journey in this difficult time. And if you would like to be part of this shared learning forum, if you could kind of just drop us an email, and then we can get you a link, and then you can engage in the conversation. And that is from me. So thank you so much for attending, and thank you so much for, I guess, being part of the network and supporting each other in this difficult time. Take care. Bye.